Excuse me, ladies and gentlemen. We now have all speakers in conference. Please be aware that each of your lines are in a listen-only mode. I would now like to turn the conference over to Chris Hunn. Sir, you may begin.
Thank you, Jennifer. Hi, everybody. Good morning to you, or good afternoon to you, or to the folks dialing in here from the other side of the Atlantic. Good evening. I've seen lots of people coming on in through the chat, so welcome all to the August monthly webinar for TeamSTEPPS. This is on improving patient safety culture to provide safer care. I'm here to host you today. My name is Chris Hund, Director of the National Implementation of TeamSTEPPS. I work here at the American Hospital Association in an organization called AHRQ. So thank you again for joining us. Just a few rules of engagement about today's webinar. You'll notice that you could listen to audio for this webinar in two ways. You can do it through the phone, and Jen has been chatting in the chat box the phone number to call if you'd like to do this. If you do this, make sure you mute your computer speakers. Otherwise, you're going to get crazy feedback. You can also listen to the webinar via your computer speakers if you have that option. So you can do both things. We will do a question and answer session at the end of the presentation. The way we like to do this is via written questions. So we have you chat in questions as you think of them in the chat box you see there on the right side of your screen. What we'll do then is we'll try to put them in some sort of order that makes thematic sense. And then our speaker, Adam, and I will go through the questions at the end of the presentation. So that's the way we like to do things. You're more likely to get your question answered if it comes in earlier. When they all start flying in at the end, it's very hard to read them and keep track of them all. But if we don't get to your question, we'll make sure to work with Adam at the end of this presentation to get your questions answered. So just a little bit more about TeamSTEPPS. We're actually funded, and so a big thank you goes out to the Agency for Healthcare Research and Quality. AHRQ is a part of the Department of Health and Human Services. They provide these webinars for free on a monthly basis. We have some other upcoming events. We have an online course that's still open and available. So you can go over to the URL you see on your screen here if you have any interest in taking the online Master Trainer course for TeamSTEPPS. Right now, all of the current in-person TeamSTEPPS training are filled up, but there will be more offered in the future. We are just sitting tight, and those will be announced shortly. Also, if you want to learn anything else about TeamSTEPPS, keep an eye open for future events. There's a national conference every year. There are these trainings. There are monthly webinars. You can pop on over to teamsteppsportal.org. That one is up available on the screen right now for you. If you ever need any help with TeamSTEPPS, not only in questions about doing a course or coming to a webinar or coming to any of our events, but also if you have content questions, if you're curious about connecting with others, you can email us at arcteamsteps@aha.org. You could also give us a call there at that phone number that you see at the top of the screen. Okay, so today's presenter we have is Adam Novak, Project Coordinator with the Michigan Health and Hospital Association. So we're very excited to have him talk to us about what's going on with TeamSTEPPS through his programs, learn a little bit more about what they're up to and what they're doing. So I look forward to hearing the presentation. I'm sure you all do as well, and I'll be back at the end to ask Adam some questions. So Adam, would you like to take it away?
Great. Thank you so much, Chris, for that wonderful welcome, and thank you very much for the opportunity to talk about something that I'm frankly quite passionate about, and that is patient safety and culture. Again, my name is Adam Novak. I'm a project coordinator here at the Michigan Health and Hospital Association's Keystone Center. I spearhead our culture initiatives here, which really entails infusing safety culture principles into our quality improvement work and I also work on our pain management efforts throughout the state of Michigan. So these are just the objectives of today's presentation. We're going to discuss MHA's program of work for improving safety culture. I'll provide an overview of CUSP and what it is and how both CUSP and TeamSTEPPS can be used together. We'll look at some popular communication and teamwork improvement tools and discuss at the end the importance of staff engagement. So I'd like to just start by providing a little information about MHA, the Michigan Health and Hospital Association. We have 293 members, and 166 of those are hospitals. Again, I work at the MHA Keystone Center, which is basically our quality improvement department. So we are currently part of the HEN 2.0 Hospital Engagement Network, that is 2.0 effort going on. And we do work around things like CAUTI, VAE, ADE, OB with early elective deliveries and post-hemorrhaging. And you may also perhaps be familiar with our two other national projects, which are actually the first one, the CUSP for MVP VAP, is a national collaborative to reduce ventilator-associated harms, and that's funded by AHRQ, and we're going actually into our last couple of months of the 3-year-long project. We had 3 cohorts of that. And then the other one that has concluded is the On the Cusp Stop CAUTI to reduce catheter-associated urinary tract infections, and that one was funded by AHRQ. So anyway, both of these national projects were use nurse-driven protocols and really were structured around the CUSP framework, and that's something that I'm going to talk about today. So just a brief overview of the MHA Culture program and sort of what we offer. The SCORE, to start out with, is a culture survey that we've moved to. We previously used HSOPS, the culture survey, and then we've moved to the SCORE, which is the safety, communication, operational reliability, and engagement, and that is organized and administered by Safe and Reliable Healthcare is the name of the organization. And toward the end of this presentation, I'll be showing a few data slides from that as well. We also do quarterly CUSP workshops. Again, I'm going to go into what CUSP is and the framework and how you can use that framework with TeamSTEPPS tools. CUSP also has some tools. But we do quarterly workshops that we host here in the state of Michigan for our member hospitals and teams that are engaging in our quality improvement initiatives. I'm also going to be talking about a tool that we push out. It was created internally called the Culture Orientation Material, and I'll explain a little bit later on why it's called that, but it's essentially a business case for culture and why it's important and what you can do, some easy first steps in improving your culture on your unit. We also have a new, what's called the Keystone Speak Up Award, and it's an award to recognize and acknowledge frontline healthcare staff in Michigan hospitals who literally speak up for patient and staff safety, and that was just launched in March of this year, and that is quarterly, so I'll talk about how that ties into one of the TeamSTEPPS tools as well, and helps to create what we like to refer to as psychological safety. We also, in the works, have a cultural roadmap. It's not finished yet, but I'll put a little plug in from here for the Minnesota Hospital Association. If you've ever heard of MAPS, the Minnesota Alliance for Patient Safety, has a ton of really great resources, and they have a pretty robust culture roadmap on their site as well, and so we're looking to do something similar. And then the last thing here, improvement toolkit. That's just really a broad way of saying we have a bunch of tools and we have a bunch of literature and best practices and information on what we call the MHA community site, and so that's kind of a forum for our member hospitals to exchange information. They can sort of chat questions back and forth, but it is password protected, so that's nice. And then this graphic you see on the right hand side of the screen is basically just a visual depiction of how we have conceptualized culture in a very broad sense. And we've done so for a while, but it's something that's continuously evolving. And so I'm not going to speak to that in each of those individual pieces, but I wanted to throw it out there just for everyone to see. So again, one of the big things that we push out at MHA is CUSP. And CUSP stands for the Comprehensive Unit-Based Safety Program. And it's basically an intervention to learn from mistakes and improve safety culture. So similar to TeamSTEPPS, it uses tools, teamwork and communication improvement tools. It provides a framework for organizing your quality improvement initiatives. So using, assembling your transdisciplinary team, having regular monthly meetings, reviewing your data, sort of a stepwise how-to on getting started, moving into implementation, and then also sustainability. But something of note is that with, regardless of whether you're looking at CUSP or some other program, culture change takes a long time, a pretty long time. And it's a repetitive process. So there's really no end in sight. And that's something that's reinforced throughout the CUSP program. And when we have our day-long workshops, it's really stated multiple times that when you get to the end, you test and see where you could improve, and then you do it all over again. And so that's basically what I've done here is list some of the steps, and you'll notice that the first and last bullet are the same. So evaluating your culture of safety, however you do that, whether it's with HSOPs, back in the day it was probably SAQ. Now, as I mentioned, we're using the SCORE and or Press-Ganey or whatever you're using, however your institution is measuring culture. It's very important to do so because it allows you to benchmark. It allows you to look at where you were, where you came from, and where you are now. And it can inform your decisions moving forward. So basically, you evaluate your culture of safety. You assemble your team. Again, I mentioned the transdisciplinary team. So you're going to pull in, different members, a nurse, a physician. You want an executive champion as well. And this is really a part of high reliability in terms of deference to local expertise. So this is a team effort. You can't achieve one thing. You can't achieve everything with one person, I should say. And so, getting input from all different angles is very important. And then you're going to educate the staff on science of safety. Again, I'll speak to this in another slide or two here, but science of safety is the name of a video that was developed and, narrated by Dr. Peter Pronovost from Johns Hopkins University, who was really one of the founding fathers of the CUSP idea, the CUSP framework, and helped to develop it and push it to where it is today. But it basically speaks to just culture, this idea of taking a systems approach, not pointing the finger. And just culture, again, isn't saying that somebody cannot be at fault for something. And there's actually an algorithm out there where you can, it says, okay, there was an event. Did this person have proper training on what happened? Yes, no, and then it takes you to another set of questions. And basically, you do this over and over again in this algorithm chart, and at the end of it, it helps guide you to make a decision. Basically, it's typically a communication breakdown or some other system level error and not an individual. Then the next thing you're going to do is identify defects and then assign an executive to adopt a unit, or basically creating a partnership with an executive, having them inform your efforts, because they can remove barriers for you. They can provide, free up time. Sometimes if you're lucky, they can free up funding for your efforts. They can help connect the dots at the higher level, maybe set you up in partnership with another department in your organization that's experiencing the same thing or working on similar things, or has, pulled learnings from what they've done and applied it. And then you're going to use your teamwork tools. And that's really where the toolkit within CUSP comes into play, and that's really where TeamSTEPPS comes into play as well. And that's a big part. And the more I'm learning about all the great things TeamSTEPPS has to offer, the more I'm getting excited about it, honestly, because the tools are just fabulous. And then again, evaluating safety at the end. So this is sort of reiterating the previous slide, but I tried to take it a half step back again and simplify even further. One of the most common feedback I get, somebody always mentions this at every single CUSP workshop I go to, no matter where it is or when it is, that CUSP, even though it sounds funny because it's in the name Comprehensive Unit-Based Safety Program, CUSP is so comprehensive. It's so hard to roll out in its entirety for a lot of different institutions that are, may not have a lot of resources. This is especially true with critical access hospitals. We had a CUSP workshop last year in the Upper Peninsula in Michigan, and so it's kind of amazing how many people don't know there's an Upper Peninsula to Michigan, but it's up there. It's part of our state, and it's very rural, and so a lot of critical access hospitals up there. And a lot of people come to me and say, we can't roll this out. We can barely get 6 to 8 people in one room at the same time. How are we supposed to have a transdisciplinary team and get everyone together and talk about these things? So this is sort of, again, I'm not a clinician, but this is my prescription for people who ask how they can get started and go through the CUSP program, but not have it so resource intensive. And basically, again, like the previous slide, identify who's on your team, and at a minimum, you want a physician champion, a nurse champion, and again, the executive is very important because they can remove so many of the barriers for you, and they can help diffuse and communicate your message up the chain and to other departments. Meetings are very important, especially a standing meeting. So monthly meetings is what is recommended in the CUSP program. And a couple sort of tips and tricks for scheduling monthly meetings, and especially when trying to pull the executive into the picture, is working with the executive assistant and piggybacking off existing meetings. So if you have a monthly meeting, just take 15 or 20 minutes on the back end of that, because everybody's schedule is freed up. Again, Science of Safety, I have linked the video in here. The word video is linked, and so on the TeamSTEPPS portal website where this presentation is posted, you could go ahead in there and click it and watch that video. It's a 20 to 25-minute video. But what you're going to do is watch this video. It's kind of a cultural primer. It gets you thinking about Just Culture, thinking about your own unit, your own workplace, whatever it may be, your team. And then you complete the staff safety assessment, and this is one of the tools I'm going to talk about in a few slides. And then again, tools to improve. I've just listed a couple there, but I'm going to go into depth on a few more. So, TeamSTEPPS, CUSP, and Culture. They are, I think the key to bridging the gap here, again, a lot of people ask, what's the difference between CUSP and TeamSTEPPS? I think that, CUSP has a toolkit, TeamSTEPPS has a fabulous toolkit. CUSP, I see it as a really good platform to arrange the various pieces of what you want to do. And again, giving you that guide, that step-by-step process to get through. And so these are some of the tools I'm going to talk about. I took 3 of what I believe to be the most popular ones. So CUSP, morning briefing, the staff safety assessment, which I really like because it's so incredibly simple, and learning from defects. Then TeamSTEPPS, again, SBAR, very popular. The CUSP tool, I really like, and I'll tell you why in a few minutes, and check back. And then some other things that we're using is STOC PDSA. So that stands for the Small Test of Change using the Plan, Do, Study, Act cycle. And then again, culture orientation materials and the Speak Up Award. So CUSP tool number 1, the morning briefing, and I should point out here as well that these tools take various forms, and they're very customizable, so you may see a lot of crossover between TeamSTEPPS, CUSP, between other tools that you've seen out there from various organizations that have been developed as well. So just putting that out there. But the morning briefing is a really nice way to structure communication in real time. And what we mean by real time is you can actually hold this sheet and you can fill it out with all your team members around you as you're going down the list. And what it does, it's sort of like a information handoff tool. You can, prompt others for information in terms of what happened last night. Was there an event on the unit? What do I need to know about? What barriers may be in the foreseeable future, and foreseeable future meaning that day. So, was there a family member that had a lot of questions and was really anxious overnight, or was a patient, really distraught about something? Where should I begin my rounds? So it's really a nice mechanism to prompt these conversations and sort of prepare you for the day. It's easy to use. Again, can be adapted, very customizable, which I really like. And it's fairly straightforward. You simply go down the list kind of like a checklist. The second tool, and again, this is one of my favorites, called the Staff Safety Assessment. And this picture right here, this is your toolkit. That's all it is. You can fit it in your pocket. It consists of basically a writing utensil, in this case a marker. These little sticky dots is what I call them, but they're basically the little things you would write, 50 cents or $1 on at a garage sale or a yard sale, and some sticky notes. And all the staff safety assessment is 2 questions. It asks, how will the next patient be harmed, and what can we do to prevent that? It's so simple, but it really prompts a lot of discussion around, where do we allocate our resources? What issue are we going to target first? And basically what you do with this, it's called dot voting. So what you do with this little toolkit here, your 3-item toolkit, is you get together as a group, you formulate your team, you sit down, everybody takes sticky notes, however many you need, 1, 2, 5, 10, and you write down as many ways, 1 per sticky note, as many ways as you think the next patient will be harmed. So, communication breakdowns might be one, or, there's clutter on the floor and it's a trip hazard, somebody might fall, whatever it is. And then what you do is you stick them up on a wall or a flip chart or a board, and you sort of cluster together the ones that fit together in terms of, the theme, communication, whatnot. And then everybody gets 3 dots, and 1 dot is equivalent to 1 vote. And so you can disperse them however you want. You can put all 3 dots on communication if you think that's how the next patient's going to be harmed. It's communication breakdowns or handoffs. Or maybe you'll put 1 there and 2 on, the environmental factors. And then you simply tally up all the dots, and it gives you an idea of what the issues are as perceived by your group. And again, high reliability, deference to local expertise. You guys are the experts, so you know better than anybody what's going on the ground level, on the front lines. And it guides you in terms of moving forward. And then tool number 3, learning from defects. Basically, learning from defects is a mini RCA. So not whenever, but a lot of times when you say RCA or root cause analysis, people start getting a little anxious, they start fidgeting a little bit. It's kind of a scary thing, but it shouldn't be. But it's got a bad reputation for being scary, for being a, finger-pointing type thing. But that's not how it should be. And learning from defects is basically a mini RCA. But whereas you would use a full root cause analysis for, let's say, a sentinel event, learning from defects could be anything. anything, minor that may have happened, but is still a near miss, and it's still an error. And so you basically just ask yourself and your team, what happened? Why? What can we do to reduce the probability that it will happen again? How do we know the risk is reduced? So measurement. And then sharing your learnings throughout the organization, which is very important. A lot of people a lot of teams, I should say, tend to get their findings. They do a good job going through learning from defects, and then they just kind of file it away. Okay, good job, everybody. Let's move forward with our lives and continue our work. But really, it needs to be shared for the greater good. So now I'm going to discuss the few TeamSTEPPS tools that I've included in here, and again, that can really strengthen something like the CUSP format that we use here in Michigan that we push out in a lot of our work, the SBAR. So it's a tool to standardize communication, direct, concise communication, and improve the accuracy. You basically give the situation, background, assessment, and recommendation. And I've heard that a lot of people just do the SBA. They get the SBA, but they don't get the on the end of it. So it's a very important part, though, because as the deliverer of the information, as the sender of the information, you may have something important to say that can add to what you're delivering. So, don't forget the recommendation part. It's very important. And the other thing is, this does not need to be so formal. A lot of people might look at this screenshot, this sheet right here, and say, man, I'm not going to, every time I want to communicate with somebody, I'm not going to grab a sheet, write down 500 different things, and, and go through every little step and then read straight from this sheet. The thing is about this that you can use it to start, use it to learn how to communicate in the SBAR format. So you might need to use it for a week or 2 weeks or 2 months or however long it takes you. You might want to start out this way, but I guarantee you eventually down the road, if you do this enough, you will go through an SBAR and not even know it. You'll just be talking to somebody, delivering some information. You'll go through situation, background, assessment, and end with a recommendation, and it'll take you 20 to 25 seconds. And that's it. That's SBAR. But it's a good teaching tool. The second one, and I really love this one, the CUSP tool. I'm concerned. I'm uncomfortable. This is a safety issue. It's a progression in magnitude of meaning. So basically what that means is, concerned, that's a flag. And ideally everybody you're working with would know this lingo. And if that doesn't work, I'm uncomfortable. And then if it goes beyond that and the person you're trying to speak up to or the group still doesn't get the hint, this is a safety issue. And that's basically like we need to have a conversation about this. And what I like about this is, again, it provides a safe way to speak up. And I'll go into the Keystone Speak Up Award and sort of what that's about, but there's a lot of crossover here between speaking up and the CUSP tool. Speaking up is a major indicator of a culture of safety and of highly reliable organizations. Being able to speak up and how that's received by others is very important. And creating this psychological safety means that people feel like they can speak up. They feel comfortable to do so. If they see that, Jane over here spoke up to Dr. Smith, and Dr. Smith got really angry at Jane and said, don't you challenge my authority, and, this and that, and sees her get her head chewed off, and I'm just picking on the doctor, but it could be anybody. It could be nurse to nurse. It could be somebody non-clinical. It could be anyone. And that person, after witnessing that, you will be more reluctant the next time to speak up to that individual because, I'm not going to put myself out there and get my head chewed off if I want to say something, and I saw this person X, Jane, the other day, get scolded for it. So psychological safety, being able to speak up, having a safe way to do it. CUSP goes about it, and it's a very ingenious way to do it because to teach speaking up, because it takes a lot of the variable of losing face, quote unquote, out of it. It's not seen as much of a challenge in front of others if you have these sort of code words, if you want to put it that way. And then number 3, the check back. So incredibly simple, but so incredibly effective. Sender initiates message. Okay, so I'm telling you something. Receiver accepts message and feeds back. You say the same thing back to me, and then sender confirms message is correct. I say, yes, that's correct, or no, something's wrong with that. Either I made a mistake, and hearing it back now has clued me into that, and we need to change something, or you may have recorded it on your end, wrongly and delivered that information back to me. And so it provides for multiple quick handoffs, multiple pivot points where you can catch information that's not right. And so, you see checkbacks, you see them all over the place. It's not necessarily in the clinical setting. For instance, last week, I believe it was last Tuesday, we had the Michigan state primaries. And so I went to vote, and I walked in our voting classroom, is where it was in my precinct. And so I walk in, I get my little slip, and I fill out my name and address and whatnot. I give it to this lady, and, there's a couple people to her right. And as I was standing there, I noticed that they were doing a check back. So she sat there and said, okay, we have Adam Novak, person to her right. Adam Novak, N-O-V-A-K, got it. And then, yes, that's correct. And then First Lady again, this is voter number, 6123 or whatever it is. And then the person to her right said the information back to her, and then she confirmed that it was correct. And they did this back and forth and back and forth. And so you see how simple it is, but how effective it can be. And in something as complex as our field, as healthcare, you can't have too many sort of nets, safety nets in place like this. And then, so this is in the quote-unquote other tools category that we use. So some things that we push out at MHA. One of them that's really incorporated into our work here, we built it into an online form, an e-form that people who are participating in our sepsis or CAUTI or pain management collaborative work are required to fill this out monthly. And so it's called the Small Test of Change, or PDSA, the Plan, Do, Study, Act format. And really what this is the scientific method, if you think about it. You plan, you have a test or an observation. How are you going to collect data? How are you going to measure success? We talked about learning from defects and how do you know you made a difference when you improve and set that plan in place. So you plan, you have your test or observation, you test on a small scale, and that's why it's called the small test of change. It's not as resource heavy as doing a full-blown campaign of some sort. So you test on a small scale, and that could even be, N equals 1. It could be one person that you're soliciting for feedback, or it could be 2 or 3. And so you do whatever it is you're changing, whatever your small test of change is. You study how those results compare to your prediction, and then you act. And in the act part, at the end of doing your plan, do, study, act, you will basically have 3 options, the 3 A's of this. You will adopt it. So your new change that you just tested, you'll just use it as is. You'll say it worked out perfectly, results were great. Let's just take this and implement it right now, full time. We can expand it, we can blow it up. Or you'll adapt, which is augmenting it somehow, improving it, saying, well, we were pretty close, but I think if we tweaked this part, and then go through our PDSA cycle again, we'll see further improvement. So you can adopt, adapt. The last one is abandon. Nothing worked, scratch it, start over. We don't think that any improvements can be made in this, but since it was a small test of change and it didn't work, we're not really, cutting our losses isn't that big of a deal. So this is something, again, that people in our sepsis, CAUTI, and pain management work in the state of Michigan, if they're in our Keystone Collaborative, that is, are required to fill out monthly. And so they're going through these little tests of change over the course of, the project, the program. And it's been quite effective for people. We've received a lot of feedback that it works and it can happen. We recommend a month time frame to measure for change, but it doesn't necessarily have to be that long. So our other tool, this is the culture orientation material, and it's called Orientation because it was originally created to be shown at, or shown to, I should say, incoming new employees in the hospital. So it doesn't matter if they're clinical, non-clinical, front office, anyone, doesn't matter. When they're getting their introduction, their onboarding, showing them, it consists of 2 slides, and it's basically, again, the business case for culture, and that's pulled out of research and so peer-reviewed articles and white papers and other things. And I will provide those references. I was made aware the other day that I had neglected to put those references in this presentation, so I will send those along, and we'll get those posted where you can pull this webinar recording from. And I believe they're all publicly available, so you can go find them. But it basically gives the why, the business case for why culture matters, how it makes a difference, as found by the research, and a few easy steps of how you can improve. So this is slide number 1 that appears there. And you can see it covers a number of different things, but basically the research suggests that staff job satisfaction increases with better culture. There's fewer staff injuries and lower burnout rates with better culture. So staff injuries specifically, in one of the articles cited for this piece, is accidental needle sticks amongst nurses. And burnout, this is something that's talked about frequently. If anybody's familiar with the work of Brian Sexton, he talks a lot about burnout and work-life balance and reducing burnout. Better culture is associated with better communication, interaction, overall teamwork. Patient satisfaction increases. Better safety climate associated with lower 30-day readmissions, mortality rates. You get the picture. These are just a few pieces. This is not by any means an exhaustive list of things of how culture can be linked to, real-life outcomes. And in the end, a thriving culture of patient safety can save lives. And then the second slide, the second piece of the orientation slide set, you could say, is just 4 really easy, simple steps, nothing too much to it. The first one, respect. I can't tell you how many times I've been talking to, a group of nurses or somebody from a hospital, and they will just look me straight in the eye and say, I wish, all I ask for is common professional courtesy. Just afford me some common professional courtesy. Speak to me like a human being, and I'm all ears. I will listen. I'll be receptive. I'll treat you with respect. And so something as simple as that, just working on our basic communication skills. So the first box here, remembering that your coworkers are your teammates. You have a common goal. Everybody's in this industry, in this field, for the safety of others, for making people better, in terms of their health, and keeping it that way. Open sharing, again, speaking up, huge indicator of a culture of safety. And when that is suppressed, when you're not able to speak up, that can be dangerous. You may miss things that can, down the road, cascade even down to end in an error. Effective communication, again, just communicating clearly, maintaining eye contact, listening actively, and prioritize patient safety. Review your organizational mission and vision statements, and if patient safety is not reflected anywhere in that, then maybe put it as an agenda item and have a conversation, because that really does set the standard of care. And then our tool number 3, again, I briefly mentioned at the beginning of this presentation that we had launched in early March at our annual Patient Safety and Quality Symposium here in the state of Michigan, the MHA Keystone Speak Up Award. And again, it's for frontline healthcare staff who speak up for patient and staff safety. It's quarterly, so we've had upwards of 80 nominees so far, and we acknowledged and awarded our first recipient on July 13th, so very recently. And we actually went to this hospital and had a nice ceremony in person. And you can see here this picture. It just speaks to the importance of this award. So not only were 40 other staff and nurses and other physicians there to support our awardee, who you can see here in the middle in the light-colored jacket, but we have on the far left of this picture is Brian Peters, the CEO of MHA, and then to his left is Frank Sardone, the CEO of Bronson Methodist, who was the recipient, or the recipient was from Bronson Methodist, was working there. And we have our awardee in the middle, Dr. Raymond, and then on the other side is Sam Watson, our Vice President of Keystone Center. So the outpouring of support was amazing to see. And basically, this award is a tool. It's saying that you have the support of everyone to speak up, and we want you to speak up. If you see something, if you think a patient's in danger, or you think a staff member's in danger, whatever it might be, it could be something as seemingly trivial as, so-and-so didn't wash their hands coming into a room. Will you please do that? Or it could be something like you're about to administer the wrong medication to an infant. Or, it could be anything along these lines. And this is very important. Again, it's a new initiative. It's really in its infancy right now, but we're trying to make this statement and going along with the idea of transparency and high liability is you can speak up, and we have your back if you do speak up. And we're encouraging you to, and you should. So having gone through these various tools rather quickly, I realize as we're approaching about 15 minutes left here, I just want to touch on engagement. Engagement is so crucial, engagement of staff. And a lot of people, approach me and ask, how do we engage physicians? How do we engage leaders? How do we engage any staff in any initiative that we're pushing out, any quality improvement, platforms that we're using? Here's a few ways, a few answers that I've been able to give to people. Include staff early. If you want to engage people, they need to see value in the work that they're doing. And one way of creating value is including them early, letting it be known that their opinions about what's going on, about the developmental phase of an initiative, and getting their input early is important and will serve you well as you move into, sustainability, implementation and sustainability. And a tip, use the staff safety assessment. Again, the dot voting, just get everyone together and solicit some feedback. Being transparent, show your data to staff, embrace and improve. And I was relatively recently, last couple of months, at a hospital on a site visit. It was a critical access hospital, and they, I won't say publicly post rates, but publicly to the staff, we'll say that, kind of in the back. They do publicly post their HCAP scores, which is great, but the staff are aware of what the issues are, what the rates are everywhere in the hospital. And when you do that, when you let everyone know what's going on, what they need to be looking out for, what the hospital your organization, whatever it is struggling with, that creates a heightened awareness for it. People are looking for it. People are sensitive to it, more sensitive to it. And I realize it might not work for everybody, but it's a really good starting point. Use patient stories. It's so important. You know, I went to IPFCC in Chicago not too long ago. It was a fantastic presentation, few-day event, and they always started with patient story, every major presentation and address to the group, and it's so important not to lose sight of that. But make it real, make it resonate with staff when you're pitching things to them. Use the patient stories. In reducing burnout, celebrate even small successes, because if you just wait around until a big success happens, you know, a huge break, you might be waiting for a little while. So small successes are key. It keeps people going. So a couple points quickly on measurement. I send out a 6-week follow-up survey after all of our CUSP workshops. And as you can see, some of the questions: have you assembled a CUSP team on your unit? Yes, and in progress. You could almost combine those a little bit, a little over half, which is not bad considering this is, you know, a comprehensive rollout, and so 6 weeks after is still quite early. And then attending a CUSP cohort webinar. It's something that's offered by Johns Hopkins. They're automatically enrolled after completing the workshop. This is, again, just some data. I won't go into depth in this, but this is available in the slide set that's going to be made available to you. And these are basically just some Likert-type questions that I included in that 6-week follow-up survey, you know, ranging from strongly agree to strongly disagree. And basically the takeaway from all this is that CUSP is generally well received by those who attend the workshops and actively engage. And, you know, it's just the common barriers that they struggle with, like everybody else does, in terms of how do we engage, you know, physicians a lot of time in this quality work? How do we engage our executive leadership? Because they are, as was mentioned numerous times in this presentation, very important and really key to success in these initiatives. So I'll just leave that for you to look through on your own. And then the last thing we're doing is, and I'm very excited about this because I'm a very data-minded person, we have benchmarked our culture data. So again, using SCORE through an organization called Safe and Reliable Healthcare. It's a newer type of culture measurement tool or technique, if you will. It looks at not only traditional metrics of culture, but also pulling in the HR side of things. And I'll show you a data slide in a minute that speaks to that. But this is just a, you know, a nice data exported slide from their platform online on work-life balance. And I just want to point out really quickly, the bottom 3 categories for, or the bottom 3 scoring for work-life balance in terms of worst to best are the 3 physician categories: staffed, physicians are attending, non-employed, and residents. So it's interesting. And nurses aren't too much higher than that either, not too far above. So everybody has work-life imbalance, you could say. This is just another data slide. Again, I'll leave it to you to look through this stuff, but safety, climate, domain, I like the, it's just a really easy way to look through the data. And then this is the last one, the HR piece. There's a bunch of other questions like this. This is just an example, but growth opportunities by position. So something, bringing the HR group into the conversations that you have when looking at your culture, considering things outside of work, like, you know, have you skipped meals? How is your lifestyle impacting work? Because if you're not healthy as a provider, you can't provide the best care for the patients that you're serving. And last but not least, I'm just going to end on, you know, why teamwork and communication. A lot of people, you know, a lot of, especially being scientifically minded, you know, teamwork and communication feels kind of like a soft science. I guess it sort of is, but here's a few reasons why you can achieve way more as a team than you can individually. And I've just listed some examples in nature. Look at orcas. I hate turning on, when I see it on the Discovery Channel, I turn it off because they're so creative and absolutely brutal when they hunt, orcas do. But it's teamwork at its best. Wolves, ants. They've been around, ants have, since the dinosaurs. I mean, they've figured this out, and they have it down to a science, and it's no less applicable for us. Layers of protection, the Swiss cheese model. By improving your teamwork and communication using TeamSTEPPS tools, using CUSP, using checkback, using the CUSP framework, standardizing care, you strengthen the fabric of your culture. You put in more layers of Swiss cheese in James Reason's model. And so that's another reason. And then the last one, essential for functionality. I want you to think for just a second, just pretend that the human body is a microcosm for your organization. What if your sensory and motor nerves stopped communicating with your brain? You probably wouldn't function too well, I would wager. And it's no different with an organization. If communication breaks down, it's going to filter through, and it's not going to send the right messages or messages at all to where they can be useful. And so communication is huge. A huge part of communication, or a huge part of teamwork, is communication. And historical implications. I'll just end with a neat little bit of information. A lot of historians maintain that in the Battle of Gettysburg in the American Civil War, if the Confederacy had had one set of walkie-talkies, two walkie-talkies, with a couple-mile range, they could have probably won the Battle of Gettysburg and affected the outcome of the Civil War. Communication is absolutely paramount. And in that case, it was troop movements and whatever, but simply being able to communicate. The historians didn't choose a nuclear bomb. They didn't choose some kind of rocket science technology. They chose walkie-talkies. That just, I think, speaks to the power of communication. So I know we have about 4 minutes left, it looks like. I'm going to send this back over to Chris and see if we have any questions, or, I'm happy to answer anything. Or I know Andrea said that if we ran out of time and you have questions, they can just email them to me as well.
Great job. That was fantastic, Adam. Thank you. And yeah, we have tons of questions. I think one of them that has come up multiple times in different ways is, how effective do you think CUSP can be when you're maybe in a critical access hospital, or if you're in a rural area where there maybe isn't, there's the same sort of resources or number of people working, and then somebody just sent in a question about in an ambulatory setting. So I think they're all kind of revolving around CUSP in environments that maybe are not traditional to what the original program was.
Yep.
Created out of Hopkins with you guys.
Yep. That's a fantastic question, and everybody who chatted that in is absolutely spot on with that, because again, Hopkins Hospital is huge, and they've been doing this since day one, and they have 1 million teams, and they have all the experts, so they can coach up very easily and very well. Whereas it's much harder, at a facility that doesn't have as many resources at their disposal. And one of the tips that I got, one of the suggestions, I should say, from one of our Johns Hopkins colleagues is, if you're in a critical access hospital, if you're in a rural area where it's more community focused, possibly, reach out for partnership. You can pull in, a member of the community, whether it's, a local church group or some other community some other organization that's in touch with the community, and you can sort of begin to outsource it a little bit in that respect. The other thing is people can, again, I hate to say wear multiple hats again if you're in a critical access hospital. That's not what you want to hear, but you could serve multiple roles. So you can, run the meetings, and you can also identify resources. You can play multiple roles within the CUSP, program within the team, and it doesn't have to be a 10-person team. It could be, 3 people. Again, you'd really like to have a physician and a nurse champion and an executive if possible. And, if you have to go to a meeting every 2 months or a quarterly meeting, you can make those small sacrifices. But I think the key point is that doing something is better than doing nothing. So if you're able to do even a piece of CUSP, even implementing a tool, and you're not able to meet regularly, all the stuff I presented is ideal. But again, rarely does the absolute ideal situation present itself.
That makes, that's a lot of things, right? I think there's one, quick little add-on. You'd brought up at one point Brian Sexton's work on burnout, and that, talk about ideal situations. I know that one of the things that he talks about is that we're not going anywhere and doing any of this great, foundational culture change work if people are, fundamentally burned out. It's just not possible to add something on. So that's just, an interesting aside, something you brought up earlier.
Yes, absolutely.
All right, well, I think we're at the top of the hour. So thank you so much, Adam. You do have some great questions that we will pass on to you, and that's always a sign of a great presentation that you got so many people talking. So thank you so much. Really appreciate it, and thanks to all the folks from around the world who joined us today. We're really grateful to have you. Thank you.
Great. Thank you very much.
Thank you, ladies and gentlemen. At this time, this does conclude today's teleconference. You may now disconnect from your telephone, log off the webinar, and have a wonderful day.